Hi, this is Mai Sargueli. Wanted to go over Cincinnati VA resident supervision guidelines and provide an orientation that's mandatory for all site directors to review. So today, what we're going to go over is some of the things that relate to new version of VHA Handbook 1400-01. So we're going to walk through some of the nuanced things that exist and speak more in generalities about what proper supervision really looks like. But what we will provide you is the adequate knowledge to understand what proper supervision looks like, so that as a site director, you can make sure that your residents and trainees and fellows are well aware of the fact that these requirements exist, and to also make sure that your supervising physicians are compliant with ensuring that the trainees are protected. And we'll get into that as we get through the presentation. So the basic tenets of supervision is exercised through direct involvement with patient and resident observation of care provided by the resident. So oversight of care and directing the learning of the resident, as well as role modeling, communication, and professional skills. So supervision, as you can see, is through direct involvement. It's granted to the trainee. Progressive responsibility is granted and documented to the trainee through competency-based education inclusive of the graduate levels of responsibility. And if you'll recall from when you participated in the orientation for site directors, is that this is in the program letter of agreement, is what is expected of trainees as they're here, and what they're capable and what they're allowed and should be doing. It that tasks or responsibilities that have been entrusted to a trainee for unsupervised executive after having attained significant competence. And this is always at the attending's discretion. So we're going to talk about this a little bit in depth, and I'll get into this after we get through the next couple pieces. But it's also the foundation for tort protection of both the resident and the attending. And lastly, that the health record, one of the major tenets of supervision is that unfortunately, there's no way to retrospectively know that supervision occurred unless you specifically go into the health record. So all this stuff that we're going to be talking about is what the documentation needs to look like in the health record, but there's a reason for that, and that's because it's our most durable foundation of what actually happened with regards to patient care. So with that being said, we're actually going to go over what is the minimum requirements. That number 3 really does imply that if a staff physician feels it's necessary to take a much more active and direct approach when it comes to resident supervision, or to do things that they don't feel the trainee is capable or competent to do, that is entirely the prerogative of the attending physician, the staff physician. And so I wanted to double back on that. The other thing I wanted to double back on is this presentation was actually modified from New Jersey Healthcare System, Dr. Dean Giacobbe, and for that I thank him. So we're going to get into the types of note signing. So there's a couple different types of note signing which you're familiar with. One is an additional signer. And this is really only designed to be a communication tool to alert a clinician to a specific document. It has no implication when it comes to patient care. It has no implication when it comes to supervision, and therefore it is not a form of supervision. If your trainees add you as an additional signer onto a note, it does not matter that they added you to that note. It would effectively be the same thing as though they didn't add you to the note at all, because it is not a proper form of supervision. With that being said, a co-signature is a co-signer may edit a note if it's not signed already, and if there's no addendum, the co-signature block actually implies that there's concurrence and that there was proper supervision, or adding a co-supervisor to a note. So now the types of supervision that exist is there's direct supervision, which is a supervising practitioner is physically present, meaning the resident and attending are co-located. This is a requirement of clinic and ambulatory patients, meaning that a trainee in a clinic or an ambulatory area must have direct supervision, meaning the staff supervisor is on site and co-located. Indirect supervision is a little bit different, and this is where the supervising practitioner is not physically co-located with the resident. But that is not to imply that the attending is not available. They must be available 24/7 when supervision is required, in a manner that ensures patient safety so that they can be accessed at all times. A common example of this would be there has to be a call physician in an emergency for surgery or for medicine, that they can provide indirect supervision, but not physically be in-house during a consult or something along those lines. And we'll get into more of this as we get through. Text messaging and emails, meaning a patient tells you, or a trainee tells you about, or tells your staff supervising physician about a patient over a text message or an email, is not considered any form of supervisory capacity. And so from a legal perspective, finding out about a patient via text message or emailing does not count as proper supervision. So that would be indirect, really does imply phone call in conversation. Indirect implies being co-located. So before we get into what the actual documentation looks like, it's important to know that the residents and the fellows have responsibilities of their own, and that they must be aware of limitations and not attempt to provide clinical services or perform procedures for which they have not achieved appropriate level of experience or capability. So with that being said, if you have a junior resident or trainee who's not capable of performing an invasive surgery or procedure, then they should not attempt to do it, even if that graduate level of responsibility says that at this level they should be able to accomplish it. If they are not able to do it, it is a form of really risky behavior if they do something that they're not able to do. They must introduce themselves to the patients and the patient surrogates as residents or fellows and explain their role in providing supervised care. So now getting on to the types of supervision. So that was effectively what the resident is responsible for when it comes to what they do and how they introduce themselves. So now we're going to spend a lot of time on what documentation looks like. So there are 4 basic types of documentation. The first one is an attending progress note. So this is a progress note written independently from a attending physician. It is a standalone note, and it is required for any admission inpatient, for any pre-op assessment, and for extended care admissions. In attending addendum to a resident progress note is acceptable for ongoing care. A co-signature of a progress note is acceptable for ongoing care. And then resident documentation of a supervising practitioner, name, summary of discussion, summary of attending's oversight with respect to the assessment, diagnosis, and plan is also acceptable for ongoing care and for the 3 things that aren't listed above, which are admission, pre-op assessment, and extended care admissions. So now let's go into what the acceptable types of documentations look like. And we're going to just focus on that last one, that Part 4, resident documentation of supervising practitioner's name, summary of discussion, statement of attending's oversight with respect to assessment and diagnosis and plan. So a couple things that are acceptable is I have seen and discussed the patient with my supervising practitioner, Dr. Gwelly, and Dr. Gwelly agrees with my assessment. You can see there's a clear indication of a conversation, of a joint decision making, of an individual attending supervisor physician who is named, and that supervising physician agrees with the assessment. The other thing that can be put in is the supervising practitioner of record for this patient is Dr. Gwelly, and he agrees with my assessment and plan. Once again, all of the major components of a clearly defined supervising physician is identified, and that they agree with the assessment and plan as laid out by the resident or fellow physician. What is not acceptable is just writing something like attending Dr. Gwelly or attending Gwelly. The difference between these 3 statements is pretty obvious, but just to lay it out is that there's no evidence that a conversation ever occurred between attending Gwelly and whoever fellow or resident that wrote that note would be. So now we're going to talk about the individual areas in the hospital. So inpatients. So within 24 hours, a supervising practitioner must meet, examine, and evaluate the patient. And this includes all weekends and holidays. So within 24 hours of the patient arriving, that the supervising physician must meet, examine, and evaluate the patient. The supervising practitioner must write personal admission note or make an addendum to the resident's admission note that includes the criteria to be effectively a standalone note. That would be an assessment and plan in H&P, and it has to be essentially a standalone note that essentially describes what they found for inpatient admissions. So now, for discharge, so documentation of supervision of discharge from inpatient settings, there's a couple things, and what I'm not talking about is the discharge summary. So there's some confusion that exists between what's called a discharge note and a discharge summary. So a discharge summary is a reflection of the hospital stay. A discharge note is the note that indicates documentation of supervision of a discharging patient from the inpatient setting. So the things that are acceptable is the attending can co-sign the last progress note that's written, the discharge note. And that discharge note has to indicate that the plan is to discharge the patient. The attending can or must co-sign the discharge instructions. The attending discharge note has an addendum to the resident note, or the resident documentation explicitly states not just that the attending is in agreement with the plan, as we've discussed before, but that the plan is to actually discharge the patient. So any of these four things are an acceptable method of discharging from an inpatient setting to indicate that the attending was in agreement of the discharge plan. And this is what we call in education a discharge note. The last thing is that attendings must also co-sign discharge summary. This is an additional requirement. One of these four things at the top are mandatory. It can be any of the four, and then that bottom is that all discharge summaries must be co-signed. Anytime that a patient is escalated or de-escalated to care, is that the supervising provider must be involved in these decisions and appropriately document this in the medical record. So if a patient is being transferred from the floor to an ICU or an ICU to the floor, there must be some clear evidence that the provider was involved in this discussion, and that the provider appropriately documents this decision. Supervisor from the receiving service must abide by the new admission documentation criteria, meaning going back to the inpatient, going back to the first couple slides, is that it has to be an independent note if a patient, or an addendum with essentially a summary statement that includes a history and physical. If the patient has come from a higher or a level lower of care, that they must abide by the new admission documentation criteria that we went over earlier. This includes admissions into and out of the ICU or extended care. So now consults. So that was all inpatient care of primary services that we've kind of gone over. Now we're going to talk about consults. So consults, the big thing is that they must indicate active involvement in patient care. And the four basic types to do this are very similar to what we've already seen. One is an attending progress note required for admission, pre-op assessment, or extended care admissions. An attending can write an independent progress note. An attending can addend a resident or a fellow progress note. A co-signature of the consult or the progress note is acceptable. And the last thing is the resident documentation of the supervising practitioner name, summary of discussion, summary of statement, and respect to the assessment and plan. All four of the things that were acceptable as inpatient, all four of the basic types of documentation are acceptable in consultation. In the ICUs, Because of the unstable nature of patients in ICUs, based on the patient condition and appropriate level of involvement, including independent personal assessments by the supervising physician, with documentation of such is required. And this is on a daily or more frequent basis. And the thought here is if a patient is really, really quite sick, they need to have an attending who is involved and active in the patient care, the highest level of supervision and the highest level of medical care that can be delivered. Um, Observation patients. So, in the rare case that a patient is released before an attending sees the patient, then what must happen is the fellow or the resident must call the attending by telephone as soon as possible, and they must discuss patient's discharge, condition, treatment, follow up, and ensure attending's concurrence. So, if the decision is made to discharge a patient from the inpatient service or as an observation patient, and the attending for whatever reason hasn't had a chance to see the patient at that moment, then it must be a conversation that discusses the patient's discharge, condition, treatment, follow-up, and to ensure that that attending is in agreement, and they must be in agreement. And then the attending must document the above in the medical record that they had the conversation with the patient, that they effectively the what happened in the conversation. In this situation, you can see that a co-signature of a resident note is not adequate, and this goes the same as AMA discharges. Obviously, an AMA discharge won't have the attending's concurrence, but the exact same things need to happen. That if a conversation can occur about discharge, condition, treatment, and follow-up, even in AMA discharges, it should be those things should be discussed with the patient, and our due diligence as physicians really needs to be executed. As for outpatients, so attendings must be physically present in the clinic anytime that there's an outpatient clinic that's going on. New patients always require a higher level of attending involvement and documentation of such. This includes an exam and face-to-face involvement with the patient. So if it is a new patient to an outpatient clinic that has never been seen before, then it is absolutely mandatory that an attending or a staff physician sees that patient both in face-to-face and does an examination. Um, the caveat to all this, and not really a caveat, but the follow-up to this is that if it is a follow-up patient, then the attending must be involved in decision making, but it's subject to less stringent involvement requirements, meaning a physician, an attending physician, if they trust, obviously, so this is all within the confines of the trust level that the staff physician has within that fellow, and this goes back to this is the minimum standard. It is absolutely okay. They have to be in clinic, but to discuss a patient's ongoing plan of care to an established patient without the attending actively seeing the patient, if it makes clinical sense. Remember that the patient is still the responsibility of the staff physician, but as you get to know your fellows and your residents, oftentimes established patients, their plans become a lot less complex, and the trust that you have in the resident or fellow appropriately is higher, and so follow-up patients have less stringent involvement requirements. The only thing that's required is that attending must be involved in decision-making process. That is to say that all the documentation stuff that indicates that the attending was involved needs to happen as well. And that can be a co-signature or the line at the end that says that the plan of care was discussed with the attending physician, or the attending physician agrees. As for our surgical subspecialties, so supervising practitioner must evaluate patient and write a pre-procedure note or an addendum to the residence note within 30 days of the procedure. This applies to both OR and procedure room procedures. So this is some of our medical subspecialties that this falls under. And this does not apply, however, to clinic or bedside procedures. So none of the outpatient clinic procedures that can be done that aren't procedure room procedures or bedside procedures. It's not a supervising practitioner does not need to write a pre-procedure note for those. But once again, they need to be involved in the care. We're going to go over a couple things that are a little less common, but home visits. So a first year intern, a PGY1, can never go to a home visit on their own without a supervising practitioner. It is always mandatory that a supervising practitioner is involved in that care, and is actively present. PGY2s can, and later PGY years can, but the attending must be immediately available via pre-specified phone number. And this is essentially as they get their higher level of autonomy, that a PGY2 can go to a home visit on their own, but must have appropriate supervision at a pre-specified, constantly available phone number. And then after the visit, the supervising practitioner must discuss each case with the resident and document using the 4 methods that we've discussed before. So telemedicine. So there's one caveat to this telemedicine conversation, and that is that this current we're currently in the middle of a pandemic, and the OAA, the Office of Academic Affiliation, has relaxed this particular standard. But I am going to go over this standard when it comes to telemedicine, simply because it is the rule. And it is what we expect it to be permanently. So supervising attendings and the trainee, the fellow, or the resident must be physically co-located in any telemedicine encounter. And then if there's such a time when an attending and a resident, if it's going to a facility, if you're doing telemedicine to a facility, then the attending and resident must both have appointments at the sending and the receiving facility if it's not part of VHA Cincinnati. So that would be if you were doing a telemedicine to a different organization, that you must have an appointment at both here and whatever the receiving organization is. And then trainees cannot participate across state lines. And there is some emergency legislation in the very moment to try to remedy this when it comes to COVID, but unfortunately, trainees are not allowed to perform any clinical care to any patient that's outside of the state line, and for us, it's outside of the state of Ohio. And this relates to effectively the license that they operate under and how the VA system works. That's potentially subject to some change as the current pandemic in May of 2020 exists, but at this very moment, May 28th, 2020, that is still the rule. Supervision review, so it is being done. So the things that we've talked about are being looked at, and they are markers of quality within our institution. The 2 groups who look at the supervisory documentation is HIMSS, the Information and Management Systems. They review it monthly, and they actually do a monthly resident supervision dashboard. And then the designated educational officer will look at this quarterly. And it is something that potentially you might have a conversation with the designated educational officer about. And hopefully this TMS in this video will help to really elicit what could be the problem, or really develop a better understanding for what could potentially be a problem. And then it is part of the internal annual audit process that the Department of Education does every year. So that's about it. The last couple things that I wanted to put out there is that proper supervision and associated documentation is really critical to ensure the best outcomes for our patient. It really does equate to the better the documentation, the better the care, and the proper proper supervision equates to excellent patient care, and improper supervision equates to a very dangerous situation that really we should have a very low tolerance for. And then from a really a practical standpoint, beyond making sure that our patients receive the best possible care, is that the first and the very last thing that everything really hinges on, if God forbid there's a tort action against either the supervising practitioner or the resident fellow trainee, which it very much can happen. If there's any thought that residents or fellows are free from any tort actions, that is not the case. So I hope that this presentation will not just dispel you of that myth, but also show you what how you can empower the trainees to make sure that they're best protected. More information on this is available through 3 different things. And I encourage everyone to review these. VHA Directive 1400-01 really relates to supervision of residents and what that looks like from a ground level. The Resident Supervision Pocket Card, which was recently updated, is available on the OA website. And it's really quite streamlined. It's a very good reference, and it is, like it indicates, a pocket card. It can be printed from the OA website, but the Department of Education can also provide them as needed. And then Local Policy 1159 is the policy within Cincinnati that relates to resident supervision. So that's resident supervision in a nutshell. I hope that this was useful, and I really hope that there's some practical aspects of this that you're able to take away from the conversation and really apply to not necessarily apply. I hope that it's all being done, but I hope that this was a useful conversation and that maybe some of the things that had been confusing are a little less confusing as to what supervision really looks like, but also why it's important. Thank you very much, and I appreciate you paying attention and listening.